A psalm of David's while ascending. How good, how sweet and pleasant for brothers and sisters to gather as one in unity. It is as sacred as the holy oil, anointing the head, streaming down through the beard of Aaron and the skirts of Miriam. As sacred as the snow-capped dew of Hermon, melting down the slopes of Sion. For there the Lord commanded the blessing, harmonious life till the end of all time. Shir ha'ma'alot leDavid, hine matov uman na'im, shevet achim gam yachad. Kashemen hatov al harosh yored, al hazakan zakan aharon, shayored al pi midotav, ketal Hermon shayored al hararei Tzion. Ki sham tziva Hashem et habracha, chayim ad ha'olam.
Shir ha'ma'alot leDavid, hine matov uman na'im, shevet achim gam yachad. Kashemen hatov
As you have heard, the words just sung are Hine ma tov umanayim shevet achim gam yachad. Behold, how good it is for all people to dwell together. And what make it even better is if you would just make sure you've turned off your cell phones. I want to thank Allison Charney, who, together with her father Jordan and Joel Fan and Laura Goldberg, sang these important words to us, these words of introduction. I'm Rabbi Peter Rubenstein, Senior Rabbi of this congregation, and I thank you for being here at this most important symposium on inherited breast and ovarian cancer. You see, as much as we Jews, we believe and treasure our own individual souls and spiritual life, I note that among the first prayers that every Jew is traditionally supposed to say in the morning is a blessing which thanks God, as the prayer says, for having formed us in wisdom and created in us many passages and vessels, which, when they all work, allow us to exist and stand before God. But what we know is that just as we are grateful for our bodies and physical health, those vessels, those passages, those cells don't always work as we would want. And thus, as we have done before, it is vitally important that we sponsor this symposium on inherited breast and ovarian cancer as a service to the Jewish community and beyond. Of course, we are able to do this with the tremendous support and good work of the experts from whom you will hear, and with the extraordinary efforts made by the listed participating organizations, all doing extraordinary and noble work. The topic of tonight's symposium will be focused on inherited risk of and genetic factors leading to breast and ovarian cancer in Jewish families, with the purpose of raising awareness of the increased risk of that disease so that all of us, men and women alike, can take these matters seriously in order to be proactive in caring for our own health. It is now my great pleasure to introduce our dear congregant, Mindy Gray, who will be followed by a fellow congregant, Stacy Sager. Mindy is a coordinator of this symposium along with other devoted congregants, Brooke Cohn, Al Goldstein, and Mara Sandler. In addition to being an extraordinary member of this congregation, Mindy's presence is uniquely relevant this evening as she, along with her husband, John, founded the Vassar Research Center for BRCA at the University of Pennsylvania and sits on the executive board of the Ovarian Cancer Research Fund. It is a great pleasure and honor to call to this podium Mindy Gray.
Do you like my teal dress? I want to welcome all of you to Central Synagogue this evening and to extend a huge thank you to Central's clergy, staff, and especially Daniel Nadelman and his associates, Rashmi and Kaimana, who worked tirelessly to bring this symposium to life. Many of you in this room helped us spread the word, and I want to thank you too. Brooke Cohen, Barbara Fedita, Al Goldstein, Mara Sandler, and I set out to organize this evening because when it comes to BRCA, we believe in the power of knowledge. Unfortunately, my journey here has been deeply personal. In 2002, I lost my sister Faith to ovarian cancer. She was only 44, and she left behind my nephew, who was just 4 years old. When she was diagnosed, it was already late-stage cancer. At the time, I had never heard of the BRCA1 and 2 mutations, which put carriers at significantly heightened risk for breast and ovarian cancer. Faith was such a carrier. If Faith had known she had a BRCA mutation, if she had been able to attend an informational evening such as this one, she might be here today watching my nephew enter his second year of high school. My sister made the ultimate sacrifice so that everyone else in our family was given the gift of knowledge and with it the tools to protect themselves. I am hoping that tonight we can share this gift of knowledge and in doing so, spare families the gut-wrenching loss of a loved one. Soon after Faith's death, I joined the board of the Ovarian Cancer Research Fund, and then a year ago, my husband John and I founded the Vassar Center at the University of Pennsylvania. The Vassar Center stands as the first comprehensive BRCA-focused institution in the world and is committed to funding cutting-edge scientific research and supporting BRCA-positive individuals and their families. We are singularly focused on ending this multi-generational cycle of pain and untimely death. I often think about my sister's name, Faith, and it certainly seems more fitting than ever as we gather in this beautiful house of worship. Tonight is about having faith that the unthinkable loss of my sister and the loss of family members of those in this room and beyond was not in vain. I am deeply honored that Barbara Walters can be here tonight, and I'm guessing she had a little something to do with why this room was packed. And now it is with great pleasure that I introduce fellow congregant, award-winning WABC television correspondent, and cancer survivor herself, Stacy Sager. In publicly chronicling her battle with breast and ovarian cancer, Stacy has inspired others to better understand their genetic risk and take action when needed. Her bravery has saved lives. Thank you.
Wow, nice turnout. I'm so honored to be here today to address you on this topic that I'm so passionate about. So there's an old Yiddish saying, and Rabbi, I'll try not to butcher it too much. Zum Schlemazel muss men euch mazel hoben, I think. It means, even for bad luck, one needs luck. Now, I thought a lot about this saying, not just because it's something my grandma Millie would have said, but I think it pertains to my life a little bit. The bottom line is, there's a little bit of luck in everything, right? Even the bad stuff. I consider myself incredibly lucky and sometimes incredibly unlucky, depending on what sort of day I'm having. I had two kinds of cancer before I turned 45. Breast cancer when I was only 30, and an early stage of ovarian cancer 13 years later. I beat both of them, and in between I got married and had two beautiful children. My breast cancer was non-invasive, detected from my very first mammogram back in 1998, which was 10 years earlier than normal because my mother had breast cancer when she was only 39, and she died from it at age 44. I had a bilateral mastectomy, I never looked back, and I've been fine ever since. Fast forward 12 and a half years, I just had my second child, and my doctor and my sister were beginning to nag me about the genetic testing, which I probably should have had right after the breast cancer when I was much younger. But I figured I already had the breast cancer. The odds were pretty strong I had the BRCA mutation. After all, there was even more of a family history for me. My grandmother had ovarian cancer. My great-grandmother survived breast cancer and died of old age. My mom was really the unlucky one with the early onset of the breast cancer, and then myself, of course. My sister tested negative for a BRCA mutation, but was told that she wouldn't know for sure that she was a true negative until I was tested. A dear friend of mine, my age, got metastatic breast cancer that same year, and I knew it was time to get tested. Not surprisingly, I do have the BRCA1 mutation. Once again, some bad luck. But what I didn't know yet is that bad luck would actually save me from something far worse. According to my doctors, BRCA1 meant about an 80% chance of breast cancer in my lifetime. Been there, done that. But also a 40 to 60% chance of getting ovarian cancer in my lifetime. And that really scared me. And so I decided to listen to my doctors, and boy, did it pay off. I went in for what was supposed to be prophylactic surgery to have my ovaries and fallopian tubes removed. Well, 10 days later, I got the call from my doctor that there was cancer all through the lining of both of my tubes. It was something called STIC, which stands for serous tubal intraepithelial carcinoma, basically a pre-invasive form of ovarian cancer. The doctors told me that in many of the BRCA cases, that's really where the ovarian cancer is starting, in the lining of the fallopian tubes. Mine hadn't even burst through the lining, hadn't even hopped to my ovaries yet. And while chemo was discussed, it was canceled after I had even more surgery, and doctors had a national discussion of my case. Seems it's pretty rare that ovarian cancer is found that early. Cases like mine are what was called a data-free zone. Basically, that meant that the smartest person in the room didn't even have the answer. And so I live my life now. I had a CAT scan. I had CAT scans for the first year and a half, actually, and now that's no longer necessary. I get CA-125 screenings. I get a lot of checkups. And yes, I'm the kind of person who brings an umbrella on a cloudy day. I truly believe that knowledge is power. If you ask me if the cancer could come back, I'll tell you, I certainly hope not. My doctors doubt it, but we can never be sure. What I am sure of is that genetic testing saved my life. If I had waited even 6 months, my doctor said I could have had invasive ovarian cancer and died. Yesterday was my birthday. I turned 46 years old. That's 2 years older than my mother was when she died. And while I wish she was here, and I loved her dearly, I know that wherever she is, she's smiling because I've beaten the odds twice now, and that perhaps my own blend of good luck and a little bad had everything to do with it.
Mindy and Sarah, thank you. From your courage, we gain strength, and I would suggest that Mindy, your sister, and Sarah, your mother, are here tonight. They're not only in you, Stacy, I'm sorry, Stacy. They're not only in you, but they're in the stories you tell, and in fact, hopefully the results that we'll garner from tonight. It's now my great pleasure to introduce our moderator for the evening, although she needs no introduction at all. For in some ways, she has been part of the lives of some of us for decades. Barbara Walters is a pioneer of American television, the first woman to co-anchor an evening news show in the United States, and an unparalleled role model for those in the field of journalism and beyond. In addition to being co-host on The View, Ms. Walters is best known as one of the top American television interviewers, having interviewed and addressed every U.S. president since Richard Nixon, interrogating world leaders and celebrities, and challenging and enlightening audiences through her powerful and thought-provoking conversations. I would like to thank her for joining us today and helping the greater New York Jewish community further understand the risk factors for breast and ovarian cancer, as well as the opportunities for prevention, early detection, and treatment. I would also like to take this moment to thank all of the supporting organizations who have graciously provided us with their informational material, which we will pass out at the end of the panel discussion. And now, one of the great icons, one of the great women of American life, Ms. Barbara Walters.
I hate being called an icon. I feel very close to all of you today because we are here discussing the same subject, and I'm very pleased to see so many men, because breast cancer, ovarian cancer, that's a family disease, and the fact that there are husbands and sons and relatives and friends who are men, I think is very, very important. The stories that I just heard were very touching. My birthday was just this past week. I wish I could say that we were the same age. And I hope that you live at least as long as I do, and for many, many more years. My birthday was well, we won't discuss it. It was so high that even the pigeons couldn't see it. I have a personal feeling. You know, when I heard the stories, I thought, there's almost no one here, I'm sure, who hasn't been touched in some way or other by cancer in the family, whether it's breast cancer, ovarian cancer, whatever the cancer may be. I'm sure that if I went through this audience, everybody would have a friend or a relative that touched them and hopefully survived this disease. In my own family, my sister had breast cancer and died from ovarian cancer. I was told at the time that there was no link, in talking to the doctors today, that doesn't seem necessarily to be the case. I had an examination that showed that I might be susceptible to ovarian cancer. That was enough for me, and I had my ovaries removed. This is not the kind of conversation that I have on The View, but I feel that I can share these details with you because we are indeed one family today. This year, the topic of BRCA1 and BRCA2 has made it into the national mainstream media, in great part from a woman who isn't Jewish, Angelina Jolie. I think she gave most of us an understanding, those of us who didn't have it, of what the disease could be. She gave courage to people who had to have mastectomies and had to have other treatment, and I think it's a wonderful thing that she was open about her own condition. And yet, despite all the news stories, one fact often goes missing, that BRCA mutations are much more common in Ashkenazi Jews, and therefore the issue of hereditary breast and ovarian cancer is even more pertinent to all of us in the Jewish community. Here are some of the facts. 1 in 40 people of Ashkenazi Jewish ancestry carry a mutation in the BRCA1 or the BRCA2 genes, a 10 times greater probability than that of the general population. Women who carry these mutations have up to an 80% lifetime risk of developing breast cancer and up to a 45% lifetime risk of developing ovarian cancer. Did you know that men can also carry these mutations, and they have an increased risk of prostate and breast cancer? So what we've done today is we've gathered together expert clinicians and researchers to learn more about these diseases, how you can determine the risks, and what you can do about them. So let me introduce to you our very distinguished panel. Each of them has experience in this area, but also has very special knowledge. I told them to argue with each other. You know, there's always that second opinion, so I expect this to be a spirited discussion with these great doctors. Let me introduce our panelists to you. Dr. Carmel Cohen, Dr. Susan Domchek, Dr. Noah Kao, and Dr. Julia Smith. Welcome. I'm just going to tell who you are, okay? I'm just going to rave about you a little bit, doctor, and then I can use the escort. Let me just tell you who they are. Dr. Cohen is a professor of clinical gynecology and obstetrics at the Icahn School of Medicine at Mount Sinai. Dr. Domchek, just raise your hand so we know which is Dr. Domchek, is the Vassar Professor in Oncology at the University of Pennsylvania, and she's the Executive Director of the Vassar Research Center for BRCA. Dr. Kauf, there we go, is the Director of the Ovarian Cancer Screening and Prevention Program in the Gynecology Service Department of Surgery at Memorial Sloan Kettering Cancer Center. And Dr. Smith is the Director of the NYU Cancer Institute Breast Cancer Screening and Prevention Program and the Associate Director of the Cancer Screening and Prevention Program for the NYU Cancer Institute. I thank you all for being here, doctors. It's a great honor to have you, and I now have 282 questions to ask you. But I'll make them short. Thank you. Okay. Thank you. All right. So, Dr. Cohen,
yes,
I said I would start with you, and that's what I'm going to do. Is ovarian cancer a death sentence?
The question is ovarian cancer a death sentence? Absolutely not. Some of my colleagues would say, hell no. Now, the problem is that it is the most virulent of the gynecologic cancers. More women lose their lives to ovarian cancer than to all the other gynecologic cancers put together. But it is not a death sentence if it's detected early, if it's treated properly by people who are experienced, and if there is a risk that is known about, it can be avoided altogether. Can you hear back there? Is it loud enough? You want us to speak up more? Just somebody say yes if you can hear. Okay. What was that, yes or no?
That's all yes. Yes. That's all
okay. If it is not a death sentence, how is it detected? In the case of my sister, by the time they found out that she had ovarian cancer, it was too late. Well, it's unfortunate that people frequently present when there are symptoms which indicate that the disease is advanced. And in Barbara's sister's case, therapy might not have been as effective as it is now. The physicians and the teams may not have been as experienced, but today it is detected either by early symptoms or due to the sensitivity of physicians who advise looking for it, or in screening programs. And once it's detected, the treatment is surgical initially in the hands of well-trained gynecologic oncologists, and then adjuvant therapy, which is selected based on the variables that are found at the time of surgery and the person's own personal history about intercurrent diseases and age. Dr. Domchek, we kept talking about BRCA1 and BRCA2. What am I talking about?
Well, BRCA1 and BRCA2.
Now, is it BRCA or is it BRCA? Which am I using? Interchangeable?
Well, I'll be honest, a company has marketed a genetic test called BRCA testing. The genes are called BRCA1 and 2, so I tend to be precise, but either one is fine. These are genes which make proteins which help the cells stay healthy. So they control sort of DNA damage repair, and everybody has them. So everyone has BRCA1 and 2 genes. What we're talking about here is mutations in those genes. Mutations is sometimes a scary word, but all that means is an alteration, a genetic change, something that's different that impacts the function of the protein and makes it not work. And if you have one of these gene mutations and the protein's less likely to work, you're at very increased risk of developing cancer.
Are these mutations, are they something that happens very often, or is it rare?
So if you look just generally in the general population, only about 1 in 500 to up to 1 in 800 people have these gene mutations. But there are certain groups that have a very significantly increased chance of having a gene mutation. One of them is, as you've mentioned, individuals of Ashkenazi Jewish descent. And we say it that precisely because not everyone's Jewish who has Jewish ancestry. So we're very careful about that. But then you get to 1 in 40. And I mean, look at around the room, right? I mean, that's 1 in 40. So it's a lot of people. We also know that certain personal history matters. So an individual with breast and ovarian cancer has a very high chance of having a BRCA1 and 2 mutation if they have both breast and ovarian cancer. So ovarian cancer, basically anybody with ovarian cancer is a candidate for genetic testing these days. I mean, this is sort of the strategy that we're at. Not everyone will have a gene mutation, but identifying the gene mutations, as we'll hear about tonight, really matter.
Dr. Smith, do we know why these mutations are more common in Jewish people?
Well, we know something about that. Is this on? Yeah. The geneticists call this a founder effect. And what that means, you can't hear, right? Let's see, is that better? I have to talk into my shirt. Okay. Geneticists call this a founder effect. And what that is basically a genetic change in a small part of a larger population. So when this happens, you end up with less genetic variation, and it's genetic. It's passed down through the generations. Now, for better or worse, Ashkenazi Jews, we sort of kept it in the tribe. We didn't intermarry for many generations.
I think you're going to have to, yeah. Say, it's hard for me to hear, so it must be hard for them. Just talk into the microphone, but don't put it right up to you.
Okay.
It's very difficult.
It's a little far. I think it's a little far down because they're having trouble hearing.
Okay. If you leave it right there.
Okay. So can you hear me now?
No. Go back to where you were.
Let's just do this.
Okay.
Thank you. So for better or worse, we kept it in the tribe, and we passed it down generation after generation. And so the Ashkenazi population has an enriched, as you heard from Susan, has an enrichment of the BRCA mutation, but we're not the only ones with the BRCA mutation.
What are some of the others, though? I mean, there are other factors besides just the hereditary?
Other factors that, besides hereditary, that can cause breast cancer? Yes, in fact, the vast majority of breast cancers are not attributable to hereditary cancer mutations. There are many factors. Some we know, some we don't know. Clearly environmental factors. There are things called low penetrance genes. The BRCA gene, the BRCA, is a highly penetrant gene.
And it runs in families.
And it runs in families. It's autosomally dominant in its inheritance. So any child born to two parents, one of whom has a BRCA mutation, will have a 50-50 chance of inheriting that mutation.
Whether it's a girl or a boy.
Correct.
And it's important to keep in mind also that it can come from the father's side of the family as well. What happens very frequently is BRCA mutations are actually inherited through the father's side and can actually equally come from the father's side or the mother's side. But there's a common misconception that because the cancer, either breast cancer or ovarian cancer, is on my father's side, I don't have to worry about it. And actually that's incorrect. Because of the way these are transmitted, it can come equally from either side.
Well, how do you determine if you have these cancer risks? And if so, what do you do about it?
Well, there are a couple of different things, and as Dr. Smith was saying, there are a number of risk factors for breast cancer. Similarly, there are a number of risk factors for ovarian cancer. Importantly, all women are at risk for these cancers. 1 in 8 women will get breast cancer in their lifetime. 1 in 70 women will get ovarian cancer in their lifetime, even if they don't have an inherited risk. But there are certain factors, and family history being the most important in the Jewish population, can dramatically increase that risk. Things that would make you want to look for an increased risk in the Jewish, and this is going to be specific to the Jewish population because these mutations are much more common. If you have a single individual on either your mother or your father's side who has breast cancer prior to age 60 or ovarian cancer at any age, it's worthwhile to consider genetic counseling and to see whether or not genetic testing.
Say that again. What are the risks that make you want to have genetic counseling? Because a lot of people are afraid to go for genetic counseling.
Okay. If you are of Jewish heritage, and even not, it doesn't have to be just Ashkenazi Jewish heritage, even Sephardic Jewish heritage is increased risk, although not as high as Ashkenazi. But if you are of Jewish heritage and have a single close relative, and that would include siblings, parents, grandparents, aunts, uncles, first cousins, who have breast cancer prior to 60 or ovarian cancer at any age, you want to consider genetic counseling and possibly testing.
And I'm going to throw out there male breast cancer too, which is we often forget about. It's unusual, but anybody with male breast cancer, that's also a trigger for genetic testing.
Right. And wait a minute. I'm not sure if this is on now, but
we can hear you.
Is it okay? But this is also important, is that DCIS now is known to be as significant a risk factor for BRCA mutations as invasive breast cancer. Okay. So we heard that story before. Keep that in mind.
Okay. And to give a little bit of background, just for example, why, when you're saying, well, yes, 1 in 40 individuals of Eastern European Jewish heritage has a mutation. But why are you that concerned if I have a family member with ovarian cancer or a family member with breast cancer? For women who are of Jewish heritage who have breast cancer prior to age 50, 1 in 10 will have a BRCA1 or BRCA2 mutation. If it's breast cancer prior to age 40 and of Eastern European Jewish heritage, 1 in 4 will have it. And if you have ovarian cancer and Jewish heritage at any age, 1 in 3 women will have a detectable BRCA1 or BRCA2 mutation. And this is why it's so important if there's a family history on either side.
Now, because we...
I mean, that's very scary.
Yes, but you also have to keep in mind...
But it shouldn't be scary. That's what we hope to convey tonight, that it's not scary. It's just empowering and it's knowledge and it gives you opportunity.
Tell me why it's not scary.
I'll tell you why it's not scary.
Right, Dr. Cohen's going to tell you why it's not scary.
As a clinician, first of all, I believe that any woman who's had breast cancer at any time in 1 or more breasts is at much higher risk for ovarian cancer than the general population, irrespective of what her testing shows.
I have a disagreement in
We
the
do.
audience.
This is good. You wanted disagreement.
Not so soon, not so soon.
Let me finish my posit.
Yes.
There is data which has now been revealed relatively recently in the Mayo Clinic survey and the various GWAS studies suggesting that women with breast cancer have abnormalities in other genetic foci, and it has not been demonstrated that those aren't at risk for ovary cancer, whereas those of us in clinical business who are in the trenches have observed that even women who have negative BRCA testing develop ovarian cancer after breast cancer. And a congregant here in this institution died of non-genetic ovarian cancer in her postmenopause. It's public knowledge. Her obituary stated it was non-genetic ovarian cancer. How would she have known that? Because she was tested. And her ovaries could have been removed postmenopausally, and she might be among us today.
So I mean, I think I would say that on the other side, there's a study by Ingham et al., Gareth Evans' group, that has 8,000 patients with breast cancer and negative BRCA1 and 2 testing, and shows no increased risk of ovarian cancer compared to the general population. The hard thing is that no increased risk of ovarian cancer is not the same thing as no risk of ovarian cancer. So we do know that it will happen, and it's not that women can make informed decisions about what they wish to do, but I think we know for sure, to get back to your initial question, that breast and ovarian cancer are definitely linked through BRCA1 and 2. And the reason it's not scary, and maybe other genes like RAD51 and all this stuff,
yes.
But the reason it shouldn't be scary is that if you know you have a BRCA1 or 2 mutation, even though you have very difficult decisions to make, and we're not downplaying that, you can make decisions to massively reduce your risk of developing breast and ovarian cancer. And that was why, to me, it's more empowering than scary.
Well, let me ask you, either one of you, this. Women now are told by their doctors to self-examine. So it works or it doesn't work, and you go to your gynecologist and they feel your breasts, and it's breast cancer, breast cancer, breast cancer. And that's important. But ordinarily, a woman doesn't come to a doctor or gynecologist and say, check me for ovarian cancer, right? So what should be done about that?
Well, there is no good screening test right now for ovarian cancer, so that's one problem. We have good screening tests for breast cancer. We don't yet have a really accurate screening test at all for ovarian cancer. But what I would say about this discussion is that, ovarian cancer in the general population is extremely rare. It's not at all rare in the BRCA population. If you have a relative who had ovarian cancer, BRCA positive or not, you have to consider yourself possibly at risk for ovarian cancer, in addition to the fact that many Ashkenazi Jewish families, many of us, don't have huge families to look at. There aren't tons of children, or there were Holocaust victims, so you can't just rely on these sort of, extensive pedigrees.
But coming to the issue of if you find out you are at risk.
Yeah.
As Dr. Smith said, at the moment, although there's some studies that have given early data that we might have some improvements in ovarian cancer screening, at the moment there is no screening test for asymptomatic women which has been shown to improve survival for ovarian cancer. But there are proven methodologies for reducing the risk of ovarian cancer in the setting of an inherited predisposition. The one thing which can be done even while a woman is in the childbearing years is oral contraceptives for as little as 3 to 6 years may reduce the risk of ovarian cancer by as much as 50%. We actually know in the general population that protection is long-lasting and can persist for 30 years beyond stopping the oral contraceptives. And for women with BRCA1 or BRCA2 mutations, we know it persists for at least 15 years after stopping. And for the women who have the tremendously increased risk of ovarian cancer because of a BRCA1 or BRCA2 mutation. And to put this in perspective, 1 in 70 women in the general population would develop ovarian cancer in their lifetime. In the setting of a BRCA1 mutation, that becomes 1 in 2. If it presents as an advanced stage, we cannot cure it. Or it is very difficult to cure. We may be able to cure in a few situations, but it's very difficult to cure. But in that group, we can actually have a proven strategy for risk reduction. Both Dr. Domchek's group and our group at Memorial Sloan Kettering have actually been doing research for over the last decade, specifically looking at prophylactic removal of the ovaries after childbearing is complete. And if
Under what conditions?
After childbearing is complete.
Why would you remove the ovaries? What is it you found?
If you have just finding that you have a BRCA1 or BRCA2 mutation. And it turns out by doing that, you actually reduce the risk of ovarian cancer by about 85 to 90%. You actually, if it's done premenopausally, reduce the very high risks of breast cancer by between 40 and 70%. And work that Dr. Domchek published about 2 years ago actually showed that removing the ovaries premenopausally, women lived longer. And we have good data that it actually will improve survival.
Yeah, but when? I mean, you know, at what point we're talking about removing the ovaries.
Right.
First of all, so what if you're not going to have a child? Does that matter? Does that change your sex life? And I'm not kidding.
Well, no, I think that this is actually the timing of when you should have your ovaries removed is a really difficult discussion that we have with individuals, because yes, it impacts things. When you remove the ovaries, you know, by age 40, which is often what the recommendations say, they say 35 to 40 and once childbearing is complete. But of course that relies a lot on what your life is like and have you finished having your kids, and there are a lot of factors, which is why, you know, one of the questions is why is genetic counseling important? It's important because it's complicated and guidelines are not your life and you have to factor that all in. And when you have your ovaries removed, you know, at that young age, yes, you go through immediate menopause and there are hot flashes and night sweats and vaginal dryness and potentially long-term complications for your bone and your heart. Now,
wait a minute.
That's
Just
all
a minute.
true. Now, wait, you didn't let me finish. But there is also...
It gets worse when she finishes.
But there's also some evidence that we can add back hormone replacement therapy and mitigate some of those symptoms. And I'd rather have somebody's ovaries out and not get ovarian cancer and give them back and make it, you know, better to have undergone oophorectomy. Now go.
I'm glad you would.
Yeah.
But the fact is that it's not that there is some evidence, there is huge evidence. Not only that, a woman can have, if she can work it out with her therapeutic team, she can have her eggs frozen. She can have her ovaries and tubes removed. They can be, these frozen eggs are still useful and can be inseminated and inserted into her uterus with no peril to her. She can have children. Or, once she knows she's at high risk, she can be followed very carefully until she doesn't want to have reproduction anymore. And even the data which has been presented by the geneticists here would tell you, that it is safer in the BRCA people to have the ovaries removed and to take hormone replacement. That even doesn't eradicate the benefit of ovary removal as far as preventing breast cancer is concerned.
But can I
think that's a fair statement.
Yes. Well, that's what our data shows.
As part of that,
one other thing.
Yes.
There were avenues of replacement which are no longer the best avenues. Now, transdermal absorption of certain estrogens eliminates the old system of oral tablets which presented a hormone that came from a different species. And there is the challenge of two species producing inflammation, which may be a precancer development. So now transdermal applications of hormones which are synthetically derived will in fact reduce the symptoms without huge penalty. And I think that there are all these options available.
Doctor, should everyone with a BRCA mutation have mastectomies?
Oh, this is
I keep going back to Angelina Jolie.
Well, that's why I don't know if Noah, you wanted to comment on Angelina
that?
because
yeah,
that was.
And do you have?
And then I'll answer.
Do you have a
one.
double mastectomy? I mean, is
Yeah.
not that it's an easy thing to do, but is that the way to go?
Yeah.
Well, there are two settings. One is a woman who personally does not have cancer, which was my understanding Angelina Jolie's experience, and then second is a woman
But she thought she might.
Who has a new diagnosis of cancer and has a known diagnosis of cancer. The thing about Angelina Jolie, I think she should be absolutely applauded for bringing this discussion very much to the forefront, because people have been very afraid to talk about inherited cancers. The one thing, and actually this was not Angelina Jolie's fault, the piece in the op-ed piece as well as additional materials she and her people put out, I thought were very balanced pieces. She said, prophylactic mastectomy is the right goal for me. But interestingly, we have very good methods of reducing risk of dying of inherited breast cancer. And I'm going to let Dr. Domchek and Dr. Smith address that. And, but the one thing which I want to mention is at Memorial, we follow the largest single institution cohort of BRCA mutation carriers in the world, and Penn actually follows one of the 2 largest multi-institution ones in the world. But after Angelina Jolie, I looked at our data and I looked at how many women with known BRCA1 or BRCA2 mutations who did not personally have cancer have elected mastectomy.
Why?
I was curious to see, is 90% electing mastectomy, is 25%? And it turns out it's about 1 in 4. It's because screening is a very reasonable option for breast cancer, even in the setting of inherited risk.
I think one of the challenges is, and this is kind of the devil's in the details of your personal story and your situation, is that, unlike ovarian cancer where our screening options are limited, most cancers are caught late stage. In breast cancer, we have better screening and most cancers are caught early. But this is where you have to have a larger discussion, and this is why it's always hard in these forums to convey the nuance. But BRCA1 and 2, we're talking about like they're the same thing, but they're not, which is the BRCA1-related breast cancers are different from the BRCA2-related breast cancers. They tend to occur earlier. They tend to be what we call triple negative. They more often need chemotherapy. So we know that prophylactic mastectomy is the most effective way to not get breast cancer. But actually, we don't have evidence right now that mastectomy necessarily saves your life. So that sounds like it should be obvious.
But if you didn't have that gene, if you didn't feel that you were particularly susceptible, why would you do this?
Well, there's another parallel story that's going on in the United States, which is that a large number of women who are diagnosed with breast cancer in one side are choosing to have both their breasts removed, regardless of whether they have a BRCA1 or 2 mutation. And so these women, it's really important to realize that if you are diagnosed with breast cancer, that having a bilateral mastectomy doesn't reduce your chances of dying from that breast cancer. What it does is decrease your chance of developing a second breast cancer. And that might sound like a subtle difference, but most women who don't have BRCA1 or 2 mutations don't have a super high chance of developing a second breast cancer. But it's never 0. So there's an interesting discussion there with this rise in bilateral mastectomies. Are we doing a good enough job as physicians? And I'm looking at Dr. Smith because I think she'll have comments of discussing this with people.
We're talking about, at this point, genetic counseling would come in. So as a counselor, what would you say? How would you answer this?
Well, I think the genetic counselors have a very important role. I just want to say something about what Dr. Domchek was saying and Dr. Kauf. It is true that generally in this country, the uptake of bilateral mastectomies is about 30% in the BRCA population. That's way higher than what it is in the rest of the world and in Western Europe. So when you're thinking as an individual about how you want to approach risk reduction for breast cancer in a BRCA carrier, there are factors we just don't understand, and there are very individual factors as well. So some, as I think was being alluded to, is a woman's own personal, tolerance for risk, because we don't know everything. And the fact is that there probably are, as Dr. Domchek was saying, there's a difference in BRCA1, BRCA2. There are probably differences in the same BRCA mutation in expression in different families. So it probably does matter. We can't count on it, but it matters if your mother and your aunt and your sister got breast cancer in their 30s compared to with that same mutation as in their 60s.
So let me ask a general question, doctor, as I look at our audience here. Breast cancer, again, our doctors tell us what to do. We have examinations and so forth. If you are concerned about ovarian cancer, should you go to your doctor tomorrow and say what? Or even if you're not concerned, should every woman here go to her doctor and say, ovarian cancer, I haven't been tested?
What you should say, and what is the most important takeaway this evening about ovarian cancer, is when you go to your provider, we used to be called doctors. But when you go to your provider as a customer, you used to be called patients. What you have to say to that person is, prove to me that I don't have ovarian cancer.
Automatically. You should automatically say, test me for ovarian cancer.
No, you've got to say, prove to me, because that phrase will immediately challenge this provider who might think, you know, I don't know anything about this. I'm her cardiologist and I'm doing primary care as an adjunct, or I'm her gastroenterologist. And if it's the gastroenterologist, he'll get a colonoscopy and an endoscopy. And if she's having symptoms, she'll float around for 3 months before somebody finally does an ultrasound or an MRI.
But doctor, every patient should go to her doctor and say...
patients who are at risk, and patients who are having symptoms,
but I thought there were no symptoms.
Well, it's no longer considered
Noah can
a
talk
silent
to this.
disease.
Noah can talk to this a lot.
Can I interrupt for 1 second, just because I was supposed to mention this? We're taking questions, and you're supposed to write them down and hand them to the side. So hopefully you're generating some questions. Write them down, hand them to the aisles, and people will pick them up. Sorry to interrupt.
Yeah, are there symptoms?
There absolutely. Ovarian cancer has for many years been thought of as a silent disease.
Yeah.
And research that has come out in the last decade has shown it's a subtle disease, but in the vast majority of time has symptoms, even when it is early stage. The symptoms that have been most useful are one of 4. Bloating, feeling full quickly after eating, abdominal or pelvic pain, or change in urinary habits, increased urinary urgency or frequency in the absence of a urinary tract infection. And if you have any of these symptoms that are occurring almost every day and lasting for more than 2 or 3 weeks, yes, you do want to go to your doctor and say, prove to me I don't have ovarian cancer, and make sure that all of these symptoms are common. All 4 of those symptoms are symptoms which all women will have at some point in their life. But if you have any of these symptoms, abdominal pain, feeling full quickly after eating, change in urinary frequency, or abdominal bloating, it's occurring every day, and it's lasting for more than 2 or 3 weeks, you do want to go to your doctor. And that's when things such as ultrasound, CA125.
These are the screening tests. Yeah.
Well, this is now, interestingly, it's a diagnostic test. Right. A woman is coming with symptoms, as opposed to, at the moment, it's not clear that in the absence of having any symptoms, that every woman should be having a CA125 or every woman should be having an ultrasound. But I'm going to actually rephrase what Dr. Cohen said for what is something that you can go to your doctor is prove I am not at increased risk for ovarian cancer. Not prove that I don't have ovarian cancer, because the only way I can do that is take you to the operating room. But by looking at your family history, looking at other risk factors, for example, do you have a history of infertility or difficulty getting pregnant? Do you have a history of endometriosis? Do you have a family history of early onset colon cancer? There are other risk factors. So I think, paraphrasing what Dr. Cohen said, is prove to me I don't have an increased risk of ovarian cancer, that I should be doing something differently, is something every woman can do.
Well, the point I make is that when you issue that challenge to the provider, that person's going to say, look, I'm at risk here. If she develops ovary cancer and I've told her she should go home and take Anacin or take Librax, or she's neurotic, go take a trip, I'm going to jail. And if that's what it takes to stimulate referrals to gynecologic oncologists or to genetic counselors or to other members of the medical community that are expert in this area, then that's what should be done. And the fact is that I will tell you, since we're in a house of worship, there is not one Jewish holiday except Yom Kippur where the vast majority of middle-aged women who have partaken in the feast of the day don't have those symptoms in my office. So it's got to be persistent, new, and otherwise unexplained.
But I have a little disagreement here.
So that they don't all go in tomorrow and tell you, what should you be looking for before you go into your office?
Well, I think they ought to review, as Dr. Kauf has said, their family history, their risk as far as it's known, if they've previously had breast cancer themselves, any one of a number of the parameters which we've raised here. And if they come up with nothing and it lasts 3 weeks, then please go and do it.
So people don't have to write furiously. One of the handouts that will be in your packet is something that was put together by the Foundation for Women's Cancer and Project Hope for Ovarian Cancer Research. It's called Understanding Your Risk of Ovarian Cancer. And in that, it's going to have 2 things in it. It's going to have features of family history which might suggest genetic risk assessment. It does break it down to individuals of Jewish heritage, but there very well may be people not of Jewish heritage in this room, or you certainly know people not of Jewish heritage, and they can be at risk too. These predispositions are seen in all racial and ethnic groups.
As much as they are in Jews?
No. They're not as common, but they are seen in every racial and ethnic group. But the other thing which we have is in that particular brochure is a description of those 4 most important symptoms. And such that if you have, as Dr. Cohen said, if they are new, if they're occurring almost every day, and they're lasting for at least 2 or 3 weeks, that's when you do want to go and challenge your physician. And so you don't have to remember it, we included it in the packet.
Right. The other thing I just wanted to emphasize, because most physicians don't ask this, but bringing up that you are of Jewish descent actually it matters. And it's amazing to me how many physicians don't ask that question, but they should.
I just want to sound a note of caution here. I think that it's absolutely right that if you have persistent symptoms, and you may think they're vague, you may not have a specific organ in mind, if you have persistent symptoms, you should go, you should advocate for yourself, and you should keep advocating for yourself till you get an answer. But there's a great deal of fear out there about cancer, and we know that women are as likely to overestimate their risk of getting cancer as to underestimate it. And we don't want people to end up with tests they don't need, procedures that they don't need, surgeries that are unnecessary, and possible complications. So I really think that you need to advocate for yourself, but you also need to know that there are times when you can be reassured.
That you can be?
Reassured.
Do most doctors, I was going to say general physicians, but they don't seem to be that. But do most doctors have an understanding of ovarian cancer, if they're not experts?
Probably not. And this is why it's important for advocacy groups to put together educational forums such as this, where we're educating our patients, we're educating our patients, our families. Additionally, professional societies are very actively trying to educate the membership. The American College of Obstetricians and Gynecologists has actually published a number of educational bulletins on hereditary breast ovarian cancer. The American Society of Clinical Oncology has done the same, but it takes time to disseminate. And so sometimes, for example, you had actually said that your physician or your sister's physician said that your sister had both breast and ovarian cancer, was not related, and both Dr. Domchek and myself immediately said, probably we would counsel differently. Now, importantly, I believe you lost your sister about 20 years ago. BRCA1 and BRCA2 were identified in 1994 and 1995. 18 and 19 years ago.
Very recent.
We have learned a great deal in that 18 or 19 years, but there's still a huge amount that we're learning, as well as, and it takes a while to disseminate. members of this panel all spend their lives thinking about breast and gynecologic cancer, but your primary doctors don't. And so this is where you have to kind of be your own advocate and look into what are some of what may be risk factors.
It's even more difficult than that. The prevalence of ovary cancer in this country is low. There are 22,000 new ovarian cancers this year. And who's at risk? Any woman with one or more ovaries over the age of 40. So we have about 150 million of those persons. The average doctor in practice would have to have 3,000 patients that he or she is seeing routinely to find one ovary cancer, if it's a general practice. That's not high on anybody's list of what's causing vague abdominal pain. Even the young obstetrician gynecologist is so busy delivering babies and providing contraception and sterilization and infertility and all the rest of it that they don't see ovarian cancers routinely. So you've got to get to one of us who are different animals that don't do anything but sit at the other end of this funnel, and we see ovarian cancers all the time.
So, doctor, you go to your doctor and say, I have this funny pain.
Yes.
Okay? And it's not, take 2 aspirin and call me in the morning. That won't work. What do? Do you say, send me to a specialist?
You the patient?
I'm the patient.
When you say to that person, prove to me successfully that I don't have ovarian cancer, that person's going to say, this is a real nag. I'm sending her to a gynecologic oncologist. Or I've known her for 50 years. I'm going to tell her to go home and be still. And hopefully the patient will say, I'm not satisfied with that answer.
The one point I want to make here is that there's 2 big sort of buckets we're talking about. One is sort of the fact that ovarian cancer does have symptoms that were previously sort of under-recognized.
Which are, say them again.
Again, persistent bloating, changes in urinary symptoms, fullness after eating, and abdominal pain that's persistent. That's the message to hear. And regardless of whether you have a BRCA1 or 2 mutation or you don't, if you have ovaries and you have those symptoms, that's stuff to talk about. And then the second part, and that's sort of the pathway there is you talk to your doctor and you get a workup or get referred. And then the second part where we started was you have a family history of breast and ovarian cancer and you're concerned about genetic risk. And that segue is we strongly urge genetic counseling, which can be done by a genetic counselor, can be done by an educated physician, but you want to hear a lot of this stuff you could probably get a sense of. It's kind of complicated, and it depends on your family history, and it depends on this and that. And you want to know what the odds are that you might test positive, and you want to start to hear about what it will mean if you do test positive. Because one of the things that we always say is that you don't just test a person, you test a family. So you need to have sort of know about the implications for other family members as you think through this and how you're going to talk to your family about it. So that's sort of the other path, the other bucket.
And one thing which I think is probably worth backtracking a little bit right now, all of us up here have been talking a lot about genetic counseling, but none of us have actually explained what that is. And so I think it's probably worth backing.
So do so.
Backtracking. Genetic counseling is a process. It's not sending a blood test. What will happen frequently in a genetic counseling program is you will meet a genetic counselor. Most genetic counselors
We can't hear you.
Okay. Most genetic counselors are actually master's trained medical professionals. They are trained to take a very detailed medical and family history. They will look at your parents, your grandparents, your aunts, your uncles, your first cousins. They will look at who has cancer in the family, who doesn't have cancer in the family, what ages were in the cancers. They will sometimes help you get additional information because many times families have a lore. Great Aunt Gertrude had some kind of woman's cancer, and trying to figure out whether or not that was in fact cervical cancer or ovarian cancer can be critical. The first process, which the genetic counseling is to put together the family history and say, does the constellation of cancers in the family raise suspicion of an inherited risk? And the most important genetic test is looking at that family tree. Many times when you look at that, you can actually provide great reassurance, because you actually have people who are coming in and say, well, I had a grandmother who had breast cancer in the 70s. I am at incredibly increased risk. I need to be getting mammograms and MRIs, and people are very worried. And one of the things which genetic counselors can do is actually provide reassurance for individuals who there isn't a suspicious of risk. If there is a suspicion of risk, the genetic counselors can talk to you about tests, frequently genetic tests, which can help clarify that risk. And they can talk to you what the genetic tests can tell you, what it can't, and what are strategies which you might do to reduce risk if you're found to have an identifiable predisposition, such as a mutation in BRCA1 or 2, or if you don't. And then no one forces you, makes you stick out your arm, and is going to take blood against your will. Genetic testing can be part of it, but it's really an educational process to look at the whole family and say whether or not the family is at risk, and then coming up with a targeted strategy to better refine that risk so you can make intelligent decisions.
And two additional points to raise there. Why it's so important to collect your family history, because we sometimes get pushback from patients, like, why do I have to track down what all my aunts and uncles died of? Is we actually can discover other genetic syndromes. It's not all just about BRCA1 and 2. So when we kind of hear that somebody just kind of got their blood sent off and no one took a family history, and then we actually look at things and it looks more like a different syndrome. There's something called Lynch, which features colon and uterine and ovarian cancer. I mean, that's why we do this, is because there's other things. And I'll also mention, because it's often on people's mind, that the Genetic Information Non-Discrimination Act was passed in 2008 and prohibits the use of genetic information to be kind of used against you. And although it has some limitations, even before GINA passed, we hadn't really seen it in practice happening. And in fact, when it was going through Congress, they were asking us for patient samples to show, why it was needed. And I don't know about you guys, but we didn't have any patients to give them because we had never really had an issue with it. But the fact that legislation exists should provide some reassurance.
Is it always necessary to know this? Isn't it sometimes? I keep using the word scary, but should everybody know this?
Yeah, I mean, this is why there's a process of genetic counseling, by the way, because for some patients, we want to go through that process with them. What worries me is that there's people out there who are too scared of the information, and even when there's gene mutations in the family and they choose not to be tested because it's scary, I would rather have someone come in and get screened, start breast MRIs, at least, talk about ovarian cancer screening, than hide. We won't force anyone to get testing, but we can come up with a strategy for screening even if they don't want to get tested.
Well, I want to make 2 points about this genetic counseling, which I think just add to this and are important. One is about what Dr. Domchek was saying. It's not just what the rest of your family has in terms of cancer. When you go to a genetic counselor, it's important to bring with you information about your own medical history unrelated to cancer, because many people don't realize that there are clues to hereditary cancer syndromes that are not related to cancer, that may be in organs you don't even think of, a lump on your skin, a spot on your cheek, things like this, mucous membrane changes. So bring with you all your family history. And the other thing I want to say, and personal history, is that the GINA Act, it was very, very helpful, but it doesn't say anything about life insurance. Right. So when I think about genetic testing for patients... By the way,
is that covered by insurance?
What?
Is genetic counseling covered by insurance?
Most of the time, yes. Yeah. But when I think about genetic testing, I divide people into 2 groups. Those who are affected with cancer, when I'm thinking about discrimination and insurance and privacy, those who are affected by cancer and those who are not. Those who are affected, I'm not too worried about the GINA Act or any other act, because the cancer in terms of insurance trumps any genetic test. Those who are unaffected, we do have to worry about it. It's usually an elective test in the unaffected, so it's important to mention the life insurance issue and have them take care of that.
Well, actually, I won't steal your mic because I realize I have one.
Yeah.
But the one thing which I would actually caution, what the GINA Act does is it prohibits using a genetic test that has occurred before diagnosis of cancer in either health insurance underwriting or employment, because many of people's employers are fundamentally their health insurer. It doesn't prohibit it being used for actuarial decisions in life insurance, though that being said, we have actually asked our patients and cannot find an example of one insurance carrier that has asked, and we now follow almost 1,400 individuals with BRCA mutations and not found one. But the reason which I'm not even sure it's as much of an issue, things which are entirely appropriate if you are getting a large life insurance policy for an insurance company to ask, is if you're asking for a $5 million life insurance policy, they will ask, did anyone in your family have cancer? Right. If your mother had breast cancer, if your sister had ovarian cancer, and you're of Eastern European Jewish heritage, although none of us have worked for an insurance carrier, I believe, they hire people like us. And they don't need a genetic test to say, we'll use this in rating.
What do you mean?
Because they're...
You get asked this question.
You're going to be, if you're applying for a large life insurance policy, the genetic test likely can only help you by saying you're not at risk. Your family history.
Although we can't have it both ways. So right now, what it appears to be, as best as we can tell, and we've had a lot of discussions internally about how we can really get this information out of the life insurance carriers, but they use the family history. So they use the family history, if you will, against you when you apply for life insurance. Well, that's just the way it is. They're allowed to do that. That's part of
it. But they say, is there cancer in your family?
Correct. They ask you and you have to answer, and if you lie, they can, not give you your policy.
If you lie, the policy won't be honored
So
after your death.
right now, what appears to be happening, to the best of our knowledge.
Suppose it's your second cousin.
Well, it's whatever they ask you, so it depends on that. But so what appears to be happening right now is that the life insurance companies largely are not asking about genetic tests, because if they ask, then they'll have to use it both ways, and it gets too complicated. So from what we've seen so far, mostly people aren't asking. But we're following that, as it sounds like, Dr. Kauf's group as well. We're following it very closely. But right now, I don't want to make this too big of a deal, because the benefits of testing are so great that, of course, it has to be a discussion. But I don't want to get too wrapped in it.
In our place, nobody has ever been challenged in that regard, and we haven't found any trouble. But there's another advantage, if I can just squeeze one. Another advantage.
This reminds me of my days on The View.
Okay.
You wanted us to be interactive.
I hope to be interactive, and I got it
right.
Okay.
But now that Noah and I are in your view, we aren't in competition with the beauty that was surrounding you.
Okay.
So the fact is that one of the other advantages, and I have sent hundreds of patients, if not thousands, for genetic counseling. I take the history in my office, we have the conversation, but I have never drawn a blood or done a genetic test in my office. I think it's the purview of a genetic counselor to do that for many, many reasons, not the least of which is that the genetic counselors have models that work very nicely in terms of translating to patients. And their models may be updated more frequently than my reading of the literature allows me to absorb, so that the patients get expert views, and they are all beautifully trained. I've never had anyone complain about going to a genetic counselor once I persuaded them to go. So I think it's a huge advantage to the general community.
Can I just, we have about 5 minutes left, do we? My timekeepers. If we can, a quick summary. We've been talking primarily about ovarian cancer. We have not talked about breast cancer. I guess breast cancer we feel is more understandable and more treatable.
Well, to finish that, we started talking about mastectomy, and I think that the issue with breast cancer is that there are more options. We have screening. If you have your ovaries out earlier, decreases risk. There's medications you can take to decrease risk. But on the other hand, having a bilateral mastectomy is the most effective way to not get breast cancer. This is why it's more of a discussion, and this is why it depends whether you're a 30-year-old BRCA1 carrier who's never had cancer and a 65-year-old BRCA2 carrier that's never had breast cancer. Those decisions could be very different, and so we try not to over summarize the options in these kind of forums, because it's a really personal decision.
Should you go when a woman goes to her doctor and she's talking about ovarian cancer, breast cancer, should she take her husband?
I invite her husband to come whenever he's in the waiting room, and I invite her to bring her husband whenever he's not in the waiting room, and I'm perfectly happy to talk to a busy husband on the telephone if he wants to take time to do it. And I'm happy to reiterate and repeat what I've told her, and she can get a copy of my printout of our interview and the conclusions and recommendations. So I think that most of us want to be as transparent as possible and as supportive as possible in terms of making a community understanding of what's going on. Because the spouse, regardless of gender, is going to be a very important supporter in this whole trip.
And remember that the kids are at 50, if there's a mutation identified, their children each have a 50% chance of having the gene mutation. So having, this is, again, it affects families. And remember that we test men too, and then the wife should come.
Do you test kids? If so, what
great
age?
question. And generally, our practice is we don't test children. There are no management recommendations for children. We don't change what we do for kids. And generally, screening starts at 25. So although we'll discuss it with any sort of an adult, but we usually test around 25 as a very general recommendation. I don't know if you guys have comments.
No, that's very similar.
Yep.
At the moment, we think there are no risks to children from having a BRCA1 or BRCA2 mutation until the mid-20s. And since we don't change management recommendations, our program is very similar. We feel very strongly we should not be taking that decision out of the child for when they reach an appropriate age to address the issue. One thing I want to just kind of clarify, because there is a difference between the age in which breast cancer risk starts and the age which ovarian cancer risk starts. Breast cancer risk for both women with BRCA1 and BRCA2 mutations can start as early as the mid-20s. And in fact, one thing which people ask is, well, I'm already doing my breast cancer screening and I'm not going to do mastectomy. I'm already getting mammograms, so what am I going to do differently? And we actually have very good data that mammograms alone is not enough in the setting of a BRCA1 or BRCA2 mutation. And the current recommendation of the American Cancer Society and the National Comprehensive Cancer Network is that women with a BRCA1 or BRCA2 mutation get both annual mammography and annual breast MRI starting no later than 30. Additionally, the combination of mammogram and ultrasound is not equivalent to mammogram and MRI. But the reason I actually kind of chimed in here is the ovarian cancer risk starts later. For women with BRCA1 mutations, the ovarian cancer risk doesn't pick up until the late 30s. For women with BRCA2 mutations, the risk of ovarian cancer by age 50 is only 2 to 3%. 51.5 being the average age of menopause in the US. And because it's going to be important to figure out what are the age-dependent risks for an individual, which is why it's going to be different approaches for the 25-year-old versus the 55-year-old. But breast cancer risks do start in the mid-20s, which is why we think that it's a reasonable time to test, because we'll change management. Ovarian cancer risks not for at least a decade after that.
And your testing is on a 6-month basis, alternating mammograms and MRIs, or both simultaneously?
People have argued both ways as to whether or not doing the mammograms and MRs together versus the mammograms staggered 6 months by the MRI, such as a January mammogram, July MRI. Right. The data has actually been inconclusive. And the problem is, from a practical standpoint, since about 30% of breast MRs come back in 6 months, that whatever you started on, you've switched. So I don't get as concerned as to whether or not they are done simultaneously or at intervals, but I want to make sure both are done annually.
Well, we tend to stagger them just because it's nice to get checked every 6 months. Right. But your point is well taken that we have these grand plans and sometimes it doesn't exactly work out the way we...
My patients demand it.
Demand every 6 months. Yeah.
I would if I were there.
Well, that's it. So we do, again, yearly MRI, yearly mammogram, and try to get them on every 6 months.
Indication is, and you know, there's been a law passed in New York just this past summer about breast density and ultrasound. So, you know, it is something to think about. If you have dense breasts, and that's very common in the premenopausal population, that you might want to have ultrasounds at the same time you're having the mammogram.
I want you to be able to get home in time to have dinner and watch all the wonderful television programs there are. So let me ask some questions that came from the audience, and we'll try to get to as many of them as possible. How much does it cost to get tested?
Okay, so right now, Obamacare, by the way, does have provisions in it that genetic counseling and testing should be covered as long as it's medically necessary. Again, define medically necessary. But in the Jewish population, the cost of the actual genetic test is cheaper, because the way that we look at this is, if looking at for BRCA1 and 2 mutations is like doing spell check of a large book. In the Jewish population, we only have to go to 3 specific pages to look, because we know where those are the common places where the mutations are. Therefore, it's actually much cheaper, and depending on the lab, it's between $400 and $600. Okay. Doing the whole thing is between $2,500 and $4,000, depending on the lab.
But importantly, the vast majority of private insurers in the United States now have criteria for offering testing, both for women, both for individuals affected with cancer as well as individuals not. There are a couple of exceptions. Because of how Medicare is put together, is if you need to be personally affected with a breast or ovarian cancer for you to be covered and have it be covered by U.S. Medicare. But interestingly, U.S. Medicare, if you've had an early onset breast cancer or ovarian cancer at any age, they will cover testing. The other group is, believe it or not, Champus, which is the insurance company for many veterans and their dependents. Because Congress has not acted, also does not cover genetic testing because of what is really a loophole.
But this is all changing in the next couple of years, because this is all applies to one particular laboratory that after, as Dr. Kauff said, the gene was cloned, those 2 genes were cloned in the mid-90s, they came out with the commercial test, and all of the tests have thus far been done through them. However, gene panels are now going to be available, and there will be ways to get around these, for many patients, these restrictions that Dr. Kauff was talking about.
Will Obamacare make a big difference? I mean, that's even, you know, they're trying to defeat it. Yeah, what did you say?
We'll see.
We'll see. Yeah, we don't know.
But I think because of the gene panels and the new panels that will test not just, you know, there's more companies that will test the BRCA, there are pathway genes that will be tested, there are associated genes, and there will be more opportunities to get around.
But it should be emphasized that most of the time this isn't, I mean, really, most of the time this isn't a problem.
It is most of the time it is covered.
Yeah.
And the other thing is
Ashkenazi
the Affordable Care Act, if it stands in its current version, which I realize could be a very big if, I don't know what is happening in Congress at the moment, the U.S. Preventive Health Services Task Force has indicated that this is what was called a level 2 or grade B recommendation, that in the setting of an appropriate family history, genetic counseling and testing is appropriate. That, under the Affordable Care Act, will be a covered service because the U.S. Preventive Health Task Force actually gave it that level of recommendation. So on the assumption that that moves forward, this will be covered for people with an appropriate family history.
Now, men also have a BRCA gene mutation, yes?
They can certainly, it can be transmitted to them and through them.
And is there a screening for men?
Well, there's increased risk to men for cancers. So men, particularly with
increased risk
of breast cancer, prostate, pancreatic
cancer. Why
cancer.
Is it increased?
The gene, the way, you know, it's interesting. We don't know exactly why breast and ovarian cancer are the main cancers that occur when you have a BRCA1 or 2 mutation, because these mutations are in every cell in your body. It's just how it sort of plays out. And for men, those risks are male breast cancer, prostate cancer. Both men and women have slight increased risks of pancreatic cancer. So there are other risks in BRCA2, slight increased risk in melanoma. So these are things that that are discussed. But for men, we don't have as great recommendations for what they should do, except that the whole fuss about prostate cancer screening should not really be directly related to BRCA1 and 2 mutation carriers who have an increased risk of prostate cancer. So we at least do talk about PSA screening in those individuals.
So I mean, do men come into your office and say, I want to be screened for BRCA?
They don't come into my office because I'm a gynecologic.
Yeah, that would be a little difficult.
That would be tricky.
I would offer them a hysterectomy gratis.
Yeah, it would be a good one. Yeah, they often come in for a number of different reasons. So again, one of the really important components is once we identify a gene mutation in the family, we very strongly recommend that all other family members have this information available so they can decide whether to get tested or not.
And it's not that rare, or is it that rare?
Well, again, in the Jewish population, it's 1 in 40, right? And then, you know, if you're a woman who has ovarian cancer and you're Jewish, it's 1 in 3. Well, it's exactly the same. 1 in 40 whether you're a man, 1 in 40 whether you're a woman. If you're Jewish, that's the risk.
Another question: do you need to remove the uterus as well as the ovaries and the fallopian tubes?
We're going to give that one to you.
Yeah. Well, I don't know what you would be moving for. I guess for ovarian cancer.
No, the trouble is in the tubes in the ovaries primarily, but it depends on a woman's age and inclination. If the uterus is removed, the patient can have hormone replacement with estrogen alone, and that reduces her risk of breast cancer probably, because the progestin that is required to protect the uterus from overstimulation by estrogen is no longer required. And the Women's Health Initiative study, which is a large study that looked at the problem of hormone replacement and whether or not it prevented heart attack and stroke, incidentally revealed that the women in that study who took estrogen alone had a diminished rate of breast cancer compared to the controls. That's a whole argument which we need to talk to.
I was just going to say, did you ever open, but since you did, do you recommend that women have estrogen?
I think if they need it, they can certainly have it under controlled circumstances and with an appropriate methodology and delivery.
It still is very controversial, though, isn't it?
Much of life is controversial.
Yeah, but you do have to be a little bit careful in the population of women who have had estrogen receptor positive tumors.
Sure. So there's a couple of scenarios. You know, if
wait. The question was put to me, do I recommend it? It didn't. The question did not specify, would I give it to someone who's already had a hormone-dependent cancer?
No, I was talking about normal so-called.
Yes, I inferred that you meant just walking around persons.
Yeah, I wasn't talking about somebody
Yes, and I think that when a woman reaches menopause, if she's symptomatic, that certainly topical estrogen can be prescribed safely and with intermittent progestational doses, or
topical, not a pill.
I would not recommend a pill. I would recommend a skin patch, which is the size of a postage stamp, which is changed twice a week. I have no investment in any of those manufacturers. And I think that that can be safely done with either supervision by the use of vaginal sonography to rule out the possibility of thickening of the lining of the uterus. And of course, she has to go for annual mammography like everybody else. But Barbara, I need to answer a question which hasn't been asked, if I can. I'm sure that most of you have thought about the issue of why haven't these brilliant people come up with a screening test for ovarian cancer? You need to understand, please, what screening means. Screening means a test applied to the general population, which is easy to deliver, reasonably economical, and which has demonstrated the capacity to diminish mortality in the group being screened. Now, when you hear all those provisos, you will understand that with a prevalence or an incidence of 22,000 cases a year of ovary cancer, if we are to do a prospective study, first of all, we have to demonstrate the utility of the study in a small group. Then we have to randomly test the population. Then we have to follow those women for the rest of, well, for a very long time to prove that having been detected by this test diminished their death rate compared to the general population who might get ovary cancer. That is a very high bar to pass. And that's why it's very difficult to do that.
Let me just, okay, I just want to, we have a bunch of questions, so I'm happy to have you add to it, but I'd like to get through some of the questions. Okay, what's the difference between BRCA1 and BRCA2, and does it matter?
Well, it does matter. The reason it matters is, one, the cancer risks, these are related but distinct cancer predisposition syndromes. As Dr. Domchek and Dr. Smith indicated, the types of breast cancer are different. The breast cancers associated with BRCA1 mutations are predominantly not hormonally responsive. The type that are associated with BRCA2 predominantly are. This has implications both as it looks at treatment, even screening, because the BRCA1 associated breast cancers are harder to screen for than the BRCA2, as well as some prevention strategies. There are medicines such as tamoxifen and raloxifene, which can be used to prevent breast cancer risk. And they likely have a role in women with some women with BRCA2 mutations, but perhaps less of a role in BRCA1, women with BRCA1 mutations, because the tumors tend to be less hormonally responsive.
Although I would argue that the studies have shown a decrease in contralateral risk in BRCA1, so it's complicated.
It's complicated.
Yeah.
In terms of the ovary, it actually matters in terms of timing of the risks. As I mentioned, only women who have a BRCA1 mutation, 10 to 20% will have ovarian cancer by the time they're 50. And that's the reason which we talk about taking out the ovaries between 35 and 40 and when childbearing is complete. Interestingly, the reason we do that for women with BRCA2 mutations is not because of ovarian cancer risk. Even if we do absolutely nothing, 97 to 98% of women with BRCA2 mutations will not develop ovarian cancer by the time they go through menopause. But the reason we actually recommend it is because it will reduce their risk of breast cancer, which can be as high as 1 in 3 by 50 to 70%. But and this becomes, and again, part of the individualized discussion which occurs in genetic counseling. I do have patients with BRCA2 mutations who have already had a prophylactic mastectomy. And do I have to put them into an early surgical menopause when their risk of ovarian cancer isn't really until the menopausal years? Perhaps not. And this is where we individualize depending on what is a gene.
Let me ask a different question. Oral contraception, does it increase the risk of breast cancer? There are many different opinions on this, it says.
There are many different opinions on this. I'm not worried about it.
Yeah, about oral contraception. Anybody worried about it?
I would prescribe it to every woman who is looking for a contraceptive method and can afford to pay the price of the pills, because the advantage in diminishing the risk of ovary cancer by 50% is huge.
I think that's what it's all about. It's about risk and benefit. And so there's clear benefits in terms of decreasing the risk of ovarian cancer.
Well, what do you think?
There's also benefits from not getting pregnant when you don't want to,
yeah,
and all sorts of other benefits.
That's what I thought you did it for, not for ovarian cancer.
And there's also other risks, which is there's a risk of blood clots, and there may be, but it's not proven conclusively, there may be a slight increased risk of breast cancer. The most recent meta-analysis didn't show it, so there's conflicting data either way. So usually what I tell people is that they should take it if they want to take it to prevent pregnancy or other reasons, but that, it all has to be factored in, pros and cons both ways.
The greatest risk for blood clots and fatal blood clots that go to the lung in a woman is pregnancy. preventing pregnancy with birth control pills is infinitesimally a risk for important blood clots compared to pregnancy.
You know, you can tell from all this discussion about meta-analysis and controversial, and it's going on for decades, which is true. Do birth control pills increase the risk of breast cancer? You can tell from that we don't have a definite answer. If we don't have a definite answer, then it's got to be a small risk, if it exists at all. So you're talking about a small potential risk of breast cancer, which can be screened, which can be caught often, and which you can intervene often in a meaningful way in terms of survival, versus preventing an ovarian cancer where we don't have screening and where it often is fatal. So I think we all sort of come down on the side of protecting yourselves with oral contraception.
Let me talk a little bit with these questions, a good question in the future. In the long term, what is being done to fix or change the DNA or the gene? Is this what you were ultimately trying to find? Yes? Somebody?
I think that's the distant future. But what I think is what all of us on this panel, I'm speaking for all of us, I think right now our best protection against ovarian cancer is prophylactic surgery. Our best prevention against removing the ovaries. Our best prevention against breast cancer in women at inherited risk is either intensive screening, which is associated with a fair amount of results in which further workup is necessary, biopsy is necessary, a fair amount of anxiety, and measurable decrease in quality of life, versus prophylactic mastectomy, which has an entire range of impact for women. And it's which is best of bad options. Where I think is for something that we can learn, we've learned a great deal in the 19 years since BRCA1 and BRCA2 were identified. But if the best we have to offer 19 years from now is prophylactic surgery or these highly anxiety-provoking screening interventions, I think everyone on this panel is going to be very saddened. And that's where work of things like Bassler Foundation, Project Hope, OCRF, all the other representatives here are really working towards research in which we can come up with better screening strategies, better prevention strategies, medication approaches, and better stratification of risk. Right now we say 50 to 85% of women will get breast cancer. Am I at the 50%? Am I at the 85%? Will it be in the
30%?
Am I the 30%? Yeah. Can we do something to better stratify risk so women can make more intelligent choices and not be faced with what right now very drastic interventions? Right. And can we limit who needs those drastic interventions?
That's what you're working on. We don't view the status quo as acceptable, and no one on this panel views what we currently have to offer as the end game. It's just where we are right now, and we know that that can be in itself very beneficial, but we want to do better so that people don't have to face these choices of the surgery, because we know it has downsides, major downsides.
Doctor, there's a question about pregnancy and its risk in BRCA carriers. If you have BRCA, if you have that gene or that mutation, do you avoid getting pregnant?
If you're interested in avoiding transmission, that's one question. If you're worried that something is going to happen during the 9 to 12 months of pregnancy and its effects, that's a whole different story.
There's something, are you talking about cancer when you talk about the something?
Yes. If it interferes with your screening and so forth. I don't feel that way. My personal view is that a decision for pregnancy should be that a woman should avoid pregnancy only if she's afraid of transmission. Now, the detection of genetically transmitted diseases by retrieving one cell from a 4-cell blastomere after conception is real and possible. And most of the Jewish genetic diseases can be diagnosed if the eggs are retrieved and, in fact, examined. And certainly the embryos can be examined when they're 4-cell creatures. And apparently putting them back into the uterus, if everything's okay, has not affected the character of the progeny. And there are very orthodox rabbis who demand that all of their worshipers who are going to marry go and get tested for the Jewish genetic diseases. And they advise them not to marry each other if they're going to have children, and they are all encouraged to reproduce because of their status. So I think that this is an ethical question as well as a biologic question. And I'm thumping on the answer because I think it's highly individualized.
But I would point out that a lot of the sort of classic, if you will, Jewish diseases like Tay-Sachs and things are recessive, so you need 2 bad copies of those. This is autosomal dominant, where you only need 1 bad copy.
I understand.
And but just in terms of some of the marriage issues are a little different, because here it is a little different. But from a biologic standpoint, though, I mean, we tell people, get pregnant if you want to get pregnant. We'll screen around you. We'll work around that issue. And this issue of pre-implantation genetic diagnostics about whether or not you want to screen embryos for the gene mutation, as you said, very personal, very, you know, that's a layer of conversation that's pretty intensive.
You know, as you talk about this, I keep thinking of sperm banks and frozen eggs, and all. We think we have a lot of problems now. Wait till we start figuring what this is in terms of who has BRCA and what is it, and do you look for the, you know, you're trying to find the perfect sperm. By the way, tell me about BRCA. What? I thought you wanted to know, you know, if I had blonde hair and blue eyes. So there's a whole world of things.
Well, this is why when we talk about pre-implantation diagnostics, we usually say things like, some people think it's great, some people think it's horrible. We're the messengers, the technology is available, and we're happy to discuss it because it's very loaded and people have very strong opinions about it.
Yes.
You have all been, I think, so interesting and so informative that I think I'll close, first of all, by thanking you. I can't imagine a better turnout. Don't you think so? And by the way, a wonderful audience. Nobody coughed, nobody walked out. So obviously you've all done something right, but we also have a very special audience. I want to close by asking the same question again that I asked in the beginning, and have you summarize. If you have ovarian cancer, is it a death sentence?
It's absolutely not. The fact is that I have to leave some take-home messages. It has been demonstrated time and time again that when a patient is treated in an institution that is experienced by gynecologic oncologists, primarily in the surgical phase, by an assortment of people like those on the stage and their counterparts in the other disciplines that need to help this patient, the survivorship is about 35% better, stage for stage, than in the general population. That's number one. Number two, on January the 1st, 2010, the survival data then published by the most reliable collector of data in this country said that there were 186,248 people alive that had had a diagnosis of ovarian cancer made. Now, they could have had the cancer diagnosis made in December of 2009 and been included. But if there are only 20,000 new or 22,000 new ovarian cancers a year, and you go back 2 years, and if ovarian cancer was so lethal, then you should have had 140,000 survivors. That's a lot of survivors. And all of us in this business have people who have reached their 10th year without a problem, and who have seen families grow, and who have gone to graduations, and who have had children. So I think that you should walk away from this meeting with a notion that it's best to prevent it, it's also essential to find it early, and thirdly, it's vitally important, as the memorial ad says, to go where we cure people. But we're blessed in this city because we have at least 6 major institutions, at least, that are well experienced and have all the appropriate experts, facilities, and philosophies to cure people with ovary cancer.
You want to summarize? I'm sorry.
Which 6 are they? Ooh, do you want to go there? We'll take that offline.
Well, you can imagine the university-based institutions, which have major centers. We have only 2 comprehensive cancer centers in this city. This is public information. One is at Columbia, one is at Memorial. The rest are hyphenated cancer centers, which are not comprehensive. The 3rd one in the state of New York is up in Roswell Park. That's a long commute, but they do very, very good work there. But these are institutions, Mount Sinai, Einstein. These are all institutions that have vetted track records for treating patients with ovarian cancer successfully. And I may tell you, if you go to the net and you see what survivorship is for advanced ovarian cancer, remember that in every institution, it will be, in any of these quote, superior institutions, anywhere in the country, the survivorship will be much higher than in the general population of SEER patients around the country.
You want to summarize? I'll give each of you the last word.
My summary here is actually really simple. Don't be scared of genetics. Know your risk, be empowered, learn the information, and then it's in your hands to decide what to do with.
And don't be afraid of asking questions.
Ask away.
And don't be afraid of second opinions.
Absolutely not. Any physician who gets offended at a second opinion, that's not good. You should run away. I welcome my patients getting second opinions because I know that I'm right, and they might as well hear from someone else too. Yeah.
But I want to echo what what Dr. Domchek and Dr. Cohen said. Number one is finding out and better understanding if you are at risk, and are you at the general population risk, and what is appropriate for that. For example, if you're at general population risk, oral contraceptives may be. If you're at inherited risk, we have to talk about more aggressive strategies for both breast and ovarian cancer risk reduction. So one is finding out your level of risk, and it's relatively easy to do. Number two, echoing what Dr. Cohen said, it does matter who takes care of, assesses risks, and manages it. It's not even just who treats it, even in terms of prevention. And in terms of a short but not inclusive list, it's pretty obvious. It's the principal teaching hospitals of academic medical centers. It will include Cornell, Columbia, Mount Sinai, NYU, Einstein.
Take the train to Philadelphia, come to Penn.
Penn.
Yeah.
But it does matter. And for example, even when your gynecologist says, well, if you have a BRCA mutation, I can do your surgery. It's not as just as important who your surgeon is, but as Sharon mentioned, that she had an unsuspected cancer.
Stacy. It's Stacy.
Stacy, sorry, I apologize. Stacy.
She's locally from.
Okay, Stacy, but as Stacy said, she had an unsuspected
But how do you find
ovarian
this?
cancer. Well, how you find that is, and we find that 4 to 5% of the time when we do a prophylactic surgery, you have to look at the entire ovary and fallopian tubes every 2 to 3 millimeters. And so it's important who the pathologist is.
How do you find the big question? You don't go through who are the best doctors, and you look and your doctor's name is not there. Has that happened to you? And your doctor's wonderful. So how do you find this doctor?
That's the reason which I'm saying. For inherited risk, which is still a relatively specialized, if you go to the major academic centers, no one picks their pathologist. but every one of the major teaching hospitals in New York, in Philadelphia, and in most major cities has academic medical centers where they have gynecologic oncologists, they have breast oncologists, they have gynecologic and breast pathologists who will look at this in a way that your community pathologist is not going to.
More than your regular gynecologist, you should go to the gynecological oncologist.
Yes, because it does matter.
Well, I would echo everything that's been said up here, and I also want to say that, you know, this is a field that has changed more rapidly than any other field I've ever seen in medicine. And so I think you should take home the message that things are very hopeful. It's not just that we're understanding risk and prognosis and predictive values, but the genetics will very soon be very important in treatment, because we are developing targeted, what's called personalized therapy, where it's targeted specifically at your cancer. Much of that is already dependent on genetics of the tumor, and it will be more and more so. So I think the field is burgeoning. It's about to split wide open with, in fact, treatment. So it's a hopeful time.
Are you talking about stem cells too?
Stem cells, certainly. I mean, we are, I think this is, actually I want to talk to you afterwards about something you said, because this is something I think is very important. There are stem cells and pluripotent stem cells in the breast itself, and that will determine sort of what way an early change, molecular change in a breast cell goes. But there are also other genetic factors that are important.
Well, this is, at least for my sitting here, having the ability to hear each of you so clearly, so informative. And I think, you know, we're in a temple. We've just passed the high holidays. I think we are blessed to have doctors like you. And I wish you all good health in this temple of worship. Good health. Thank you for being with us. Thank you, Doctor.
Thank you so much.
Thank you so much. Thank you.